Good evening, everyone. Thank you for joining us today. I am Fazum Badda. I'll be the moderator for the Indigo team today. And today we have very interesting topics. We're going to speak about osteoporosis, presented by Dr. Mohamed Eltag, Dr. Johnson Ayodeji, and then we're going to move on to how to start a Cochrane library by Dr. Razan Mohamed, and also learning how to record the video on Loom by Ahmed, Yasser, Shaban, and Dr. Shaymaa Abdelmalek. And then we're going to have previous fellows join us to speak about nephrology and geriatric fellowship programs, who are Dr. Azza Abubaker and Dr. Wail Alsafi. I would like to ask the first presenters, Dr. Mohamed Eltag and Johnson Ayodeji, to please share your screen and start your presentation. Thank you. Please unmute yourself, Dr. Mohamed Eltag. We can see your screen clearly. Thank you.
Hello, everyone.
Hello, your voice is clear. Thank you.
Okay, thank you, Dr. Mafaz. Hello, everyone, and welcome to our presentation. I am Dr. Mohamed Eltag. Me and Dr. Johnson are going to present to you a topic about osteoporosis. Hope you enjoy it. Our objectives today are to be able to describe how to diagnose osteopenia and osteoporosis, the pathogenesis of osteoporosis, the common secondary causes of bone loss, FRAX as a tool to predict osteoporotic fracture risk, prevention and treatment strategies for osteoporosis. We will cover the osteoporosis definition, a simple term and a more advanced term, epidemiology and impact, bone remodeling and bone loss with age, risk factors for osteoporosis, prediction and diagnosis of fractures, prevention and treatment, and lastly, vertebral fracture management. So a simpler term, osteopenia is a decrease in bone mass. Osteoporosis is a marked decrease in bone mass. So there's levels to this. There's no clinical symptoms until fracture. That's why screening for high-risk individuals is highly recommended, because the first symptom is usually the fracture itself. Osteoporosis affects trabecular bone more than cortical bone. Areas with high trabecular bone content are the spine, the head of the femur, which is the hip, and the wrist or distal radius. Osteoporosis is the most common metabolic bone disease. It is a major cause of morbidity and mortality, and it leads to a decreased quality of life. A BMD measurement or a bone mineral density at any site of equal to or less than 2.5 standard deviation below the young adult standard, with or without previous fracture, or a T-score less than minus 2.5. A T-score is measured using a DEXA scan, which we will go through in just a moment. Primary osteoporosis is age-related, and this is the more common type. Secondary osteoporosis is a result of other diseases or medications. We will also go in details through the secondary causes of osteoporosis. It can be diagnosed clinically in those at risk who sustain a fragility or a low trauma fracture. A low trauma fracture is defined as any non-pathologic fracture that occurs from a fall from standing height or less. Another point in primary osteoporosis is also called senile or postmenopausal osteoporosis. All are the same concept. Calcium, parathyroid hormone, and alkaline phosphatase are usually normal in level. That's why we don't depend on these three to monitor or to screen. Sorry. Osteopenia, as we said, it's a low bone mass, T-score less than -1, but greater or equal to -2.5. T-score is determined by a DEXA scan, and a normal T-score is 1 or higher. Epidemiology of osteoporosis, it affects people of all ethnic backgrounds. In the US, there is 2 million osteoporotic fractures annually, 1 in 2 postmenopausal women, and 1 in 5 men over the age of 50 will have a fracture in their lifetime, with the serious consequences decreasing the quality of life, the function, and the independence. A meta-analysis that was done found that excess mortality risk persists for at least 10 years after the hip fracture. Hip fractures are associated with a 2.5-fold increased risk of future fractures. In 2005, the total direct healthcare costs were estimated at 19 billion, and by 2025 the number is expected to rise to 25.3 billion. Bone remodeling. Bone is always actively remodeling. Bone resorption done by osteoclast and bone formation by osteoblast. The cycle may become unbalanced, leading to osteoporosis. After menopause, with aging in men and women, bone resorption increases more than bone formation, resulting in a net bone loss. Bone loss leads to osteopenia first, then osteoporosis, and then eventually fractures. Lifetime changes in bone mass. During puberty to mid-20s and 30s, at 30, the bone mass reaches its peak in both women and men, and then mid-30s to 40s in women, a few years of stability, then a very slow rate of bone loss, minerals loss, and also it depends on the risk factors. We will talk about the risk factors in details in just a moment. Then in the mid-40s to 50s, with the age of menopause, there is a rapid bone loss of 7% or more per year for 7 years. And then mid-50s to late life, maybe 70s, there is a continue of bone loss, but at a lower rate of 1 to 2% per year. This is for women. For men, from the mid-30s to the mid-50s, there is a few years of stability, then a slow bone loss that is dependent on the risk factors. From the mid-70s to the late life, there is a rapid cortical bone loss of 7% per year. The risk factors are low calcium intake, smoking, alcoholism, certain drugs, decreased physical activity, endocrine status, and comorbid diseases. We will talk about all of this in just a moment. So the risk factors for osteoporosis can be divided into intrinsic factors and extrinsic factors, including genetic, endocrine, nutrition, as we just said. In genetics, the heritable traits account for 75 to 80% of a person's peak bone mass. Other diseases which are heritable are also associated with a higher risk of osteoporosis, like diabetes. Sex hormone traits and sensitivity is also genetically sex hormone imbalance. Estrogen deficiency leads to bone loss by increased resorption and increased osteoclast activity. After menopause, there is a natural decline of estrogen levels, which is associated with increased risk of osteoporosis. Estrogen has both direct and indirect effects on osteoclast. The cells are responsible for bone resorption and bone loss, which are osteoclast, act through multiple pathways to decrease expression of human receptor nuclear factor kappa, also known as rank L, the major cytokine that promotes development and differentiation of osteoclast. Estrogen also has direct effects on cells of hematopoietic lineage, including osteoclast precursors. In men, bioavailable testosterone and estrogen decreases with aging due to increase in sex hormone binding globulin. Approximately half of men over the age of 70 years have bioavailable testosterone below the normal reference range of young adults. Fracture risk is inversely related to estrogen levels in postmenopausal women. We will talk about the hormonal changes of men in more details in a few slides. Sex hormone imbalance in men. Androgens are important determinants of peak bone mass in young men and fall gradually as men age. An increase in sex hormone binding globulin leads to a decrease in bioavailable testosterone. Severe male hypogonadism can cause osteoporosis. In men, severe hypogonadism can be due to pituitary tumors or androgen deprivation treatment. In patients getting treated for prostate cancer, for example. The effect of moderate decrease in testosterone levels in aging men or rate of bone loss is uncertain. Estradiol in older men has been positively associated with bone mineral density. Insufficient skeletal loading and lack of exercise. Weight-bearing bones requires a level of stress from gravity while walking and dynamic strain of muscular contractions maintain bone mineral density. Exercises that stresses or mechanically loads bones reduce BMD loss in the spine and hip in postmenopausal women based on Cochrane review. Weight resisting training is the most important. Strength training, aerobics, Tai Chi, this is similar to yoga and walking. Calcium and vitamin D insufficiency, aging skin and decreased sunlight exposure and decreased conversion of 7-dihydrocholesterol to vitamin D3 by ultraviolet light leads to vitamin D deficiency, leading to decreased calcium absorption. Older Black Americans are at particular risk of vitamin D deficiency as they age due to the nutritional habits and skin. Older adults tend to ingest inadequate amount of calcium and vitamin D. Also, there is impaired intestinal absorption of calcium due to disease or aging. Secondary hyperparathyroidism, vitamin D deficiency contributes to accelerated bone loss, promotes muscle weakness that can increase the risk of falls and leads to secondary hyperparathyroidism. Parathyroid hormone increase in order to maintain the serum levels of calcium. When chronically elevated, parathyroid hormone is a potent osteoclastic stimulator of bone resorption. Trials showed that supplementation of both vitamin D and calcium can reverse secondary hyperparathyroidism, increase bone mass, and decrease bone resorption and fracture rates, and possibly the frequency of falling. Extrinsic factors such as nutrition, exercise, and use of certain medications. Also smoking. Smoking increases the risk of fractures in both current and former smokers. Moderated more by the amount of nicotine smoked and how recently one quit smoking than by the duration of tobacco use. Alcohol, drinking more than 3 ounces of alcohol per day, early and or later in life, increase the bone loss and fracture risk. Diagnosis and prediction of fracture. Osteoporosis is a preventable disease. However, it is often not diagnosed until a fracture occurs. Earlier, we said that the first clinical sign is usually the fracture. The National Osteoporosis Foundation recommends clinical assessment of osteoporosis risk factors for all postmenopausal women and men over the age of 50 years old. The diagnosis of osteoporosis should be considered in any older adult with a fracture. BMD, bone mineral density, measurement is used to establish the diagnosis of osteoporosis in those at high risk clinically, but without a prior fragility fracture. Risk factor for osteoporosis. These risk factors are associated with an increased risk of fracture independent of the bone mineral density, which is age, postmenopausal women, and age more than 70 in men. Female sex, low body weight, BMI less than 20, 10% decline in weight from usual adult body weight, physical inactivity, glucocorticoids, previous fragility fracture as adult, current smoking, low dietary calcium, white or Asian race, alcohol intake, more than 3 drinks per day. Modification to reduce the risk of osteoporosis, exercise. Encouraging regular weight-bearing exercise, at least 5 times per week for 30 minutes. Nutrition, encouraging the adequate intake of calcium, 1200 milligram per day in divided doses to minimize toxicity. And vitamin D3, 800 to 1000 international units per day. Encourage smoke cessation, avoid excessive alcohol consumption. Medications that increase the risk of osteoporosis, you should use with caution. Glucocorticoid, which is the most important one. Use is an important secondary cause of osteoporosis, the glucocorticoids being the most common culprit in men and women. An estimated 2.5% of people age 70 to 79 years take an oral glucocorticoid. Glucocorticoid-induced osteoporosis is caused by an early increase in bone resorption. Increased fracture risk may be present with daily dosage as low as 2.5 to 7.5 milligram per deciliter. The risk of glucocorticoid-induced osteoporosis may not return after cessation of the drug use. Anticonvulsants also is a risk factor for osteoporosis because it is a P450 enzyme inducer, which break down vitamin D, leading to low calcium, and parathyroid hormone increase bone resorption. Long-term heparin also increase bone resorption. Thyroid hormone replacement, methotrexate, calcineurin inhibitors, and a lot of more drugs, but the most important one is the glucocorticoids. Secondary causes of osteoporosis, male hypogonadism, vitamin D insufficiency, idiopathic hypercalciuria, malabsorption, often celiac disease, multiple myeloma, glucocorticoids, primary hyperparathyroidism, solid organ transplantation. The most commonly reported secondary causes of osteoporosis in men include hypogonadism and excessive alcohol intake. Androgen deprivation therapy with gonadotropin-releasing hormone to treat prostate cancer reduces bone mineral density from 3% to 7% per year and increases the risk and rates of fracture. Men are more likely to have secondary cause of osteoporosis than women, with up to 50% of men having a secondary cause. But in general, the primary cause of osteoporosis is more common than the secondary. But in the secondary category, men are more common. Recommended initial laboratory testing in those with osteoporosis, fasting comprehensive metabolic panel, including albumin and alkaline phosphatase, serum phosphorus, 25 hydroxy D concentration, serum parathyroid hormone, thyrotropin, 24-hour unique collection of calcium and creatinine, CBC, serum testosterone. Idiopathic hypercalciuria is found in 10% of the general population. It is an important cause of osteoporosis, and it is diagnosed using the 24-hour urinary calcium excretion of 4 milligram per kilogram, more than 4 milligram per kilogram, and can be treated with a thiazide diuretic. When evaluating a patient, you should start with taking a thorough history to uncover the risk factors that may lead to bone fragility. Important to understand the setting in which the fracture occurred. The physical exam is directed towards detecting signs of fracture as well as assessing for secondary causes. So the key elements of the physical exam include height, weight, posture, mobility, nutritional status, and overall build. We should measure the vitamin D level, measure bone density, the use of biochemical marker in clinical practice is controversial. Dual energy X-ray absorptiometry, known as DEXA scan, can measure hip, anterior posterior spine, lateral spine, calcaneus, and wrist. The central, which is the proximal femur and lumbar spine, is preferred method of measurement. Limited data to determine the frequency of screening or the age to stop screening for osteoporosis. USPSTF, which is the US Preventive Services Task Force, recommends BMD testing for all women age 65 and older, regardless of the risk factor status. And women below the age of 65 should be screened if their 10-year fracture risk is equal to or greater than that of a 65-year-old white woman without additional risk factors. There is insufficient evidence to recommend screening in men below the age of 50. But they also recommend in men age 50 to 69 years old with diseases or medications known to increase the risk of osteoporosis, for example, the glucocorticoids. And for men over the age of 70, regardless of the risk factors. Several considerations are important when evaluating bone mineral density of the spine over time. BMD of lumbar vertebrae, L1 to L4, should be measured when making a decision about therapy. Proximal femoral neck BMD is preferred because it is more likely to be free of osteoarthritic changes and is most associated with the fracture risk. It is critical to scan a patient on the same DEXA machine and in the same position, given that uncountable intermachine differences can substantially impair the ability to detect statistically different changes in the BMD over time. Vertebral, arterial, or lymph node calcification, any type of calcification, as well as any scoliosis, can falsely increase the bone mineral density of the anterior posterior spine DEXA. FRAX is a tool. It uses data, algorithm of clinical and BMD information to model the 10-year fracture probability in men and women. It is free online. You should just Google FRAX and it appears. But it is not valid in patients who have or are currently on osteoporosis treatment and those less than 40 or older than 90 years old. It does not give valid fracture risk if spine BMD is low and femoral neck BMD is normal or shows osteopenia. It is limited to 4 ethnicities: white, black, Hispanic, and Asian. It uses 7 clinical risk factors: previous fracture, parental history of fracture, previous fracture, current smoking, glucocorticoid use, rheumatoid arthritis, secondary osteoporosis, alcohol consumption of 3 or more drinks per day. And it uses the brand of the DEXA machine or DEXA scanner being used. Vertebral fracture assessment. Vertebral fractures are highly associated with future fracture risk and morbidity. Can be present in patients with T-scores greater than -2.5. It is used as an adjunct to BMD testing. Suggested indications for vertebral fracture assessment when results will influence clinical decision making. Example regarding beginning medical therapy for bone loss, or there is a documented height loss of more than 2 centimeters, or historical height loss more than 4 centimeters in postmenopausal women with osteopenia, or more than 3 centimeters, or historical height loss more than 6 centimeters in men with osteopenia. When there is long-term glucocorticoid use, meaning more than 5 milligram of prednisolone or equivalent for 3 or more months, or history or findings suggestive of vertebral fracture not previously documented. This is when we use the vertebral fracture assessment as an adjunct to the BMD testing. These are the 5 indications. biochemical markers of bone turnover can be used clinically to provide an early assessment of treatment efficacy. A decrease in the level of these markers from the baseline after 3 to 6 months of therapy may indicate a therapeutic response. But the use in clinical practice is controversial because of high within patient variability and gaps in understanding the magnitude of biochemical marker necessary to prevent bone loss or, more importantly, fractures. Therefore, routine measurement is not recommended. Again, clinical use is controversial because of substantial overlap of values in women with high and low bone density or rate of bone loss. Few studies have compared the response of a particular marker and bone density with goals of therapy. So we only use it as to know the efficacy of the treatment from the baseline when starting the treatment. Routine measurement is not recommended. Dr. Johnson will continue with the treatment.
Yes, Dr. Mohamed, it seems like Dr. Johnson has trouble with the internet. Can you present
Hello,
the?
can you?
Yes, we can
Hello?
hear Dr. Johnson.
Yeah,
Yes.
hello everyone. Sorry, my name is Dr. Johnson. Well, currently now I'm in Nigeria and I've been having issues with the internet. But let me start now. And if you cannot hear me, please let me know. That means it's the internet. Is that a problem? Can I start now?
Yes, you can start. We can hear you clearly. Thank you.
Thank you so much. So I want to share my screen now. Just give me a minute. Okay. Can you see my screen?
Yes.
Okay. So I'm gonna start now. But please, if you do not hear me, just know it's the internet. Okay, so from preventing and treating osteoporosis, the best treatment we start with, like the first line, is usually exercise. Then we can give calcium and vitamin D. The pharmacological options include bisphosphonates. We have selective estrogen receptor modulators. We have calcitonin, estrogen replacement. We have parathyroid hormone. We have Rankel inhibitors like denosumab and other investigational agents. And also we monitor. Marked decrease in physical activities or immobilization, decline in bone mass. Walking, a weight-bearing exercise can be recommended for all adults. Start slowly and gradually. Increase the number of days and time spent walking each day. Regular exercise is positively associated with BMD, and starting an exercise program even late in life can help to preserve BMD. Calcium and vitamin D, one of three. Calcium recommended requirements includes, like, for example, in postmenopausal women greater than 50 years old and men greater than 70 years old, we usually give them 1,200 milligram per day of elemental calcium. For men within 51 to 70 years old, we give 1,000 milligram per day of elemental calcium. The upper intake for all groups is 2,000 milligram per day. Most patients require some form of additional diary or calcium supplementations to ensure adequate intake, as the average dietary intake of calcium for postmenopausal women in the United States is 500 to 700 milligram per day. Sorry, yeah, milligram per day. Sorry. Vitamin D recommended requirement for men. Oh, don't just okay. Vitamin D recommended requirement for men and women 51 to 70 years old. We usually give 600 international units per day, and men and women greater than 70 years old, we give 800 international units per day. For upper intake limit for all groups is 4,000 international units per day. Many patients may require higher level of supplementation to achieve serum 25 or hydroxide vitamin D concentrations of greater or equals to 30 ng per milliliter. All patients should limit vitamin D intake to less than 4,000 international units per day. There is disagreement on vitamin D monitoring and target 25 hydroxy vitamin D concentration goals. For vitamin D insufficiency, has been commonly defined as 25 hydroxy vitamin D between the level of 21 and to 29 ng per milliliter. Vitamin D deficiency as a level of less than 20 ng per ml. The American Geriatric Society 2014 consensus statement continues to emphasize treating to a target serum of 25 hydroxy vitamin D concentration of greater or equals to 30 ng per ml. Approved for osteoporosis prevention in postmenopausal women and for treatment in men and women. BMD and decreased fractures at the spine and hip in postmenopausal women, vertebral fractures rates, a band donate, all-cause mortality when given post-hip fracture and approved for prevention of osteoporosis in those on glucocorticoid therapy, zoledronic acid. Can be given weekly. We have alendronate, risendronate, or monthly risendronate in bandronate. Optimal duration of treatment is unclear. Expert opinion recommends discontinuation of treatment when a person is no longer ambulatory or has life expectancy of less than 2 years because of risk for fracture. So, the side effects of bisphosphonates includes, starting from the GI, we have abdominal pain. They could have dyspepsia. They could have esophagitis, nausea, vomiting, and diarrhea. They could have musculoskeletal pain and lethargy. They could also have osteonecrosis, although it's not common though. They usually have osteonecrosis of the jaw and atypical fracture, very rare in patients being treated for osteoporosis. Acute phase response usually have, all those flu-like symptoms like fever, myalgia, arthralgia, and headaches after zoledronic acid. Atypical fractures, we usually see them in the subthoracic or the diaphyseal femur. In those that have used bisphosphonates for equal or greater to 5 years. Now, we are in this table, we're going to compare the medication, the dosage, the special consideration, and, like the outcome. So, for example, when you give a patient alendronate acid, we usually, like, the dosage is usually 70 mg per week or 35 mg for prevention. And adherence to dosing instruction required. Used in men and women to prevent glucocorticoid-induced osteoporosis. Vertebral fracture, absolute risk reduction, ARR, is equal to 7.1%. Number needed to treat is equal to 14 over 3 years. The hip fracture, ARR, that's an absolute risk fracture, is equal to 1.1%. Number needed to treat is 91 over 3 years. Now, for recent joint, it is a little bit different. We use 35 mg per week or 150 mg per month. The adherence to dosing instructions should be required. Vertebral fracture, absolute risk ratio is equal to 5%. Number needed to treat is equal to 20 over 3 years. Non-vertebral fractures, Absolute risk ratio is equal to 4%. Number needed to treat is equal to 25 over 3 years. Patients' populations were not comparable, so direct comparison of absolute risk ratio and number needed to treat may not be valid. So we have ibandronate and zelendronic acid. So for ibandronate, we usually give, sorry, give me a minute. Yeah, we usually give 150 mg per month or 3 mg IV every 3 months, treatment only. Adherence to dosing instruction required. Vertebral fracture, absolute risk ratio is equal to 4.9%, while number needed to treat is equal to 20 over 3 years. For zelendronic acid, 5 mg per year IV for treatment, 5 mg every 2 years for prevention. Adherence to dosing instructions usually required. Morphometric vertebral fracture, absolute risk ratio is equal to 7.6%. Number needed to treat is equal to 13 over 3 years. Clinical vertebral fracture, absolute risk ratio is 2.1%. Number needed to treat is equal to 48 over 3 years. All non-vertebral fracture, absolute risk ratio is equal to 2.7%. Number needed to treat is equal to 37 over 3 years. Hip fracture, absolute risk ratio is equal to 1.1%, and number needed to treat is equal to 91 over 3 years. Again, patients' population were not comparable, so direct comparison of absolute risk ratio and number needed to treat may not be valid. Now, if you want to prescribe a patient, if you want to give a patient biphosphonate, we usually give them certain instructions before we prescribe the drug. For example, such instructions include you have to take it first thing in the morning before eating or drinking anything else. Also, you have to tell them to take it at least with 8 ounces of plain tap water. Take it while upright in a chair or standing and remain upright for 30 minutes after ingestion. With alendronate and risodonate, do not eat or drink anything for 30 minutes after ingestion, 60 minutes for ibandronate. Now, monitoring biphosphonate therapy. Patients taking biphosphonate are encouraged to report new jaw, groin, or thigh pains to their healthcare providers. Associated with atypical fractures, trochanteric and diphyseal femoral fractures, rarely associated with osteonecrosis of the jaw. Absolute Hello?
Yes, we can hear you.
Okay, sorry, because you logged me out, so I have to start. Okay, 1 minute, give me 1 minute, let me. Okay. Discontinuation of biphosphonate therapy. The optimal duration of treatment with biphosphonate is also unclear. The FLEX study suggests that alendronates can be discontinued after 5 years of treatment in patients at low risk for future fracture. The American Association of Clinical Endocrinology's guidelines recommends a drug holiday of 1 to 2 years after 10 years of therapy. Expert opinion recommends discontinuation of biphosphonate when a person is no longer ambulatory or has remaining life expectancy of less than 2 years. Further research is needed. Now, if you are giving there's this selective estrogen receptor modulators, SEMs, like all those tamoxifen and naloxone. The mechanism of action, it differs. Or sorry, there's a difference between the mechanism of action for tamoxifen and for valoxifene. But usually we use valoxifene because it acts as an estrogen agonist in the bone and in the heart, acts as a estrogen antagonist in the breast and the uterine tissue. But tamoxifen acts as agonist in the uterine, and that's why it can cause endometrial cancer. That's by the way. So potential for preventing osteoporosis or cardiovascular disease without the increased risk of breast or uterine cancers. Raloxifene, approved for osteoporosis prevention and treatment in postmenopausal women, usually give 60 milligrams per day. In comparison with placebo, vertebral fractures, breast cancer relative risk of 0.24, bone turnover and maintains BMD, and increased risk of venous thromboembolism and fatal stroke. Side effects may include flu-like symptoms, which includes fever, hot flushes, leg cramps, peripheral edema, also approved for breast cancer prevention. Calcitonin, one of two, rationale, hormone inhibitor of bone resorption. In comparison with placebo, vertebral fracture, spine bone density, no increase in hip or non-vertebral fractures. Possible analgesic effect in women with painful vertebral compression fractures. In 2013, FDA recommended against the use of calcitonin to treat osteoporosis in postmenopausal women because of a potential increased risk of breast cancer. Calcitonin 2 of 2. So for dosing, we usually give subcutaneous injection 100 international unit 3 to 5 times per week, or nasal spray 200 international unit per day, alternate nostrils. Fewer reported side effects, greater patient acceptance, may be less effective. Adverse effects include hypocalcemia, nausea, vomiting, allergic reactions, and possible increased risk for cancer. For estrogen replacement, prevent bone loss at hip and spine when initiated with 10 years of menopause. Not recommended as first-line choice for osteoporosis. Women's Health Initiative showed increased risk of hip fracture, vertebral fracture, and colon cancer, but increased risk of breast cancer, heart disease, stroke, venous thromboembolism. USPSTF guidelines advise against routine use of estrogen plus progesterone for prevention of chronic conditions in postmenopausal women. So for parathyroid hormone, it increases bone formation and resorption, increases spine and hip BMD in osteoporotic men and women. It reduces vertebral and non-vertebral fractures in postmenopausal women. Typically reserved for those with severe osteoporosis and fracture history. Teriparatide, 20 mcg per day, SC, for patients who cannot tolerate other treatments. Preferred treatment of glucocorticoid-induced osteoporosis. Black box warning, contraindicated in patients with Pickens disease or who have history of skeletal irradiation because it has shown that it could cause osteosarcoma. Denosumab, human monoclonal antibody that inhibits Frankel receptor activator for nuclear factor Kb ligand, decreases bone turnover and increases bone mass density. FDA approved for postmenopausal women at high risk of fracture or in those who have failed or are intolerant to other therapies. Reduces risk of vertebral, non-vertebral, and hip fractures versus placebo. Dosage 60 mg subcutaneous every 6 months. Osteonecrosis of the jaw is a rare side effect. Strontium vanillate. It's an anabolic agent, increases bone formation and decreases bone resorption, is not approved in the US. Investigational agents, for example, romosozumab, is an anti-sclerotine monoclonal antibody
Yeah, seems like Dr. Johnson has trouble with his internet. We can wait for 2 seconds or 2 minutes. Just hopefully he will be able to join us. Okay, since Dr. Johnson will not be able to join us, I'll just continue from where he stopped until he's able to join us, hopefully soon. So as he spoke about extraneous renalate agents, we're going to discuss the investigational agents such as romosozumab. It is an anti-sclerostin monoclonal antibody that inhibits the activity of sclerostin. It increases bone formation and decreases bone resorption. So the FDA has not approved the medication because of concerns about cardiac adverse events. When it comes to monitoring, serial BMD, while on therapy is common, 2 years interval currently covered by the Medicare, there is no evidence for modifying treatment based on BMD. Serial BMD useful to identify patients who are losing BMD, not adherence to treatment, secondary causes of osteoporosis that is not being treated, failing treatment. Compliance with treatment, especially with bisphosphonate, should be confirmed at each visit. Poor compliance is associated with an increased risk of fractures, as we know. Vertebral compression fractures. Asymptomatic is the majority of cases. It is diagnosed incidentally by spinal radiographs. There's increase in kyphosis or decrease in height, or closes may not fit properly over time. Chronic back pain due to spinal changes that occur with vertebral compression. When it comes to symptomatic, pain usually lasts 2 to 4 weeks and can be debilitating. How to manage it? How to manage vertebral compression fractures? Treat the pain associated with vertebral fractures if it interferes with ADLs and quality of life, regardless of the cause. Treatment options: medications is the cautious use of NSAIDs, calcitonin, narcotics commonly required for pain control. When it comes to physical therapy, it is important for both acute and chronic pain, postural exercises, alternative modalities for decreasing of pain. Education and support groups in order for the patients to relate in terms of this chronic condition and the chronic painful condition. Vertebroplasty and kyphoplasty, surgical options for treatment of pain compression fractures. In 2009, 2 randomized controlled trials showed no significant difference in pain reduction between the vertebroplasty and placebo group at 1 to 6 months of follow-up. Currently, the American Academy of Osteopathic Surgeons recommend against vertebroplasty. Recommendations: do not routinely repeat VMDs more than once every 2 years. Do not perform population-based screening for vitamin D deficiency. When it comes to the summary, osteoporosis is prevalent among older adults and is associated with high personal and financial cost as well as mortality. Osteopenia and osteoporosis can be diagnosed by measuring BMD, usually dual energy X-ray absorptiometry, DEXA scan. Evaluation of patients with osteoporosis should include assessment for secondary causes of bone loss. Osteoporosis prevention and treatment combines risk reduction, exercise, calcium and vitamin D supplementation, hormones, and other pharmacotherapies. Pain of osteoporotic vertebral fractures can be treated with NSAIDs, calcitonin, and narcotics, as well as physical therapy. We have a few cases, so please I'll read the case out and the MCQ choices, and you can feel free to unmute yourself or use the chat to answer. So our first case is an 80-year-old woman comes to the office to establish care. She has taken alendronate 70 milligram weekly for the past 7 years because of a decrease in bone mineral density. Records indicate that her lowest T-score is negative 2.22 in the right femoral neck. She has no history of fragility fracture or height loss. There is no family history of hip fracture. She has smoked 1 pack of cigarettes per day for 50 years. She rarely drinks alcohol. At today's visit, she is advised to quit smoking and arrangements are made to monitor her body density over time. Which one of the following is the most appropriate management for her bone health? Continue alendronate and add teriparatide, discontinue alendronate and switch to teriparatide. Please use the chat or feel free to unmute yourself. Yes, so I see lots of A's, C's, and D's. Thank you for answering. Let's see the answer. And the answer is C, to discontinue alendronate. Is Dr. Johnson with us currently?
Oh, yeah, sorry, I'm here now. Do you know, I didn't even know when the network went out.
Oh, I'm so sorry.
I
Yeah.
didn't finish the slide and I saw that you guys were not connected. I'm sorry.
No, no, it's fine. It's fine. Would you like to continue from the second case? I can
Yeah,
share the
it's
screen
not,
and you
it's
can read the.
not a problem. My network is been misbehaving lately. So let me. Yeah, let me get this. I have the slide. I just want to open to where I stopped.
Yes.
I stopped at this case, right? The second case, right?
Yeah, the second case, please.
Okay, yeah. Let me share the screen. Thank you. Can you? Okay. Can I share the screen? I can't share because you're already sharing. Can you?
I stopped sharing, so you should be able to share your screen now.
Okay. Can you?
We can see your screen. We cannot hear you very well, Dr. Johnson.
Hello, everybody.
Hello, Dr. Ahmed.
How are you
Can
today?
We're doing very good. Thank you very much.
Excellent. Okay, very good.
So
Everybody,
that I couldn't
Hello,
see. Yeah, it's a
the
small font. Couldn't read.
okay. Hello, everybody, and welcome to our today's session. And could we start, or we have to wait a little?
we actually started, Dr. Ahmed,
Oh, you started. What time?
at 2 p.m. EST.
Oh, so I'm sorry. I came late. Is it you start an hour earlier?
Yes, yes. We still did not finish the first presentation. We're at the cases. We're just waiting for Dr. Johnson as his connection is a bit.
Okay, no problem. No
yes.
problem. Okay,
Thank
so last time you started at 2 my time, right?
It was 2 p.m. EST as well. I'm not sure.
Okay, sure. I think my time is 2 o'clock. Sorry for the inconvenience, but I'm gonna listen and comment. So go ahead. Still, we are discussing osteoporosis.
Yes, we're still discussing the osteoporosis. We're at the case number 2. we're waiting for Dr. Johnson, the presenter, to join us as his connection is a bit delayed.
Okay.
I believe you should continue, Dr. Mufaz.
Yes, we can just go
Yeah.
for the second case, yeah. Okay. Yes, so our second case is a 69-year-old postmenopausal woman. She comes into the office because she is concerned about her bone health. She does not have a personal history of fragility fracture. Her mother sustained a left hip fracture after a fall at age 68. Bone densitometry DEXA done 4 years ago showed osteopenia. She is at low risk for fracture based on her fracture risk assessment score, FRAX. History, she has a type 2 diabetes mellitus, well controlled for 15 years, previously with a thiazolidinoid, and currently with a sodium glucose cotransporter 2 inhibitor. Recently, her hemoglobin A1C was 7.2%. She quit smoking 10 years ago and she rarely drinks alcohol. Arrangements are made for repeat DEXA scan, including trabecular bone scoring. Which of the following is true about this patient's trabecular bone score? It is associated with an increased risk of osteoporotic fracture in postmenopausal women with type 2 diabetes mellitus. It entails additional imaging and radiation exposure for the patient. It can be used to monitor the response of osteoporosis treatment. Her low score is correlated with low risk fracture. And please use the chat or unmute yourself to choose an answer, please. Thank you. Yes, I see an A, D, or C. Anyone else? Okay, more A's. Let's see what is the answer. And the answer is A. Thank you very much. And the answer is A. It is associated with an increased risk of osteoporotic fracture in postmenopausal women with type 2 diabetes. Our last case is a 70-year-old woman, postmenopausal. She comes into the office to discuss her treatment regime for osteoporosis. 3 months ago, she had a screening DEXA, and it showed a T-score of negative 2.7 at spine, negative 2.8 at the right femoral neck, and negative 2.6 at total hip. She began alendronate 70 mg by mouth weekly. She adheres carefully to the drug regime. She takes alendronate on an empty stomach with a full glass of water every Sunday, and she stays upright for more than 1 hour afterwards. She maintains adequate calcium and vitamin D intake. She recently fractured her right femur in a fall. Laboratory finding: she has normal CBC, normal renal function, calcium and vitamin D levels, and a normal 24 urinary calcium excretion. Fasting serum CTX, the C-terminal telepeptide of type 1 collagen, a measure of bone turnover, is in the lowest 25th percentile for postmenopausal women. Which of the following is the most appropriate management for this patient? Stop alendronate and start teriparatide. Stop alendronate and start zoledronic acid. Stop alendronate and start denosumab, or continue alendronate. And please unmute yourself or use the chat to choose an answer. Okay, I see D's and A's. Okay, let's see the answer. The answer is D. Well done. It is to continue alendronate. This was the first presentation. Thank you very much for joining us. I would like to thank the presenters, and if you guys have any questions, we can Give you guys a couple seconds. Thank you.
I would like to, I haven't attended the whole or the presentation, but I would like to add some remarks. First, you hear me?
Yes, we hear you, Dr. Ahmed.
Yeah, so osteoporosis is a very important topic in the field of medicine, especially talking about females who are more than 65 years of age, and the screening for females above age 65 is a routine. But how about men? There is no definitive evidence that men has to be screened at the age of 65, but sometimes we will screen when there is risk factors. One thing I would like you to remember, and the malabsorption, and people who has people who has history of malabsorption, especially celiac, they can develop osteoporosis at an early age. I see some patients who are in their 40s who have
نحن عارفين ان احنا معقدين ما المفروض يكون عندنا بلد.
Sahar, can you mute yourself?
يعني
Everybody stay muted.
يلا نخلي الشورت كويس تقدر تلعب خفيف.
excuse me, there is a background noise. Sahar iPhone, I think, need to be
Sahar,
muted.
can you mute? Okay. Go.
Yes, so the one thing I would like to add is celiac, which is can give rise to osteoporosis because of the malabsorption of calcium. And remember, there is no routine for screening for men, but usually sometimes when there is a fracture or there is other history of steroid use, you can always screen for osteoporosis. Thank you.
Thank you very much, Dr. Ahmed. Yes.
We can go to the next presentation, I guess.
Yes.
Or if someone has a question, he or she can ask.
No, I have just an addition. I believe steroid use is also a very common risk for osteoporosis. And every patient who is in high dose and long-term use of steroid should be also screened for this regularly. Yeah. Thank you.
Absolutely. Thank you, Razan.
If there's no other questions, we can go to the other next topic about Cochrane Library by Dr. Razan Mohamed. If you're ready, Dr. Razan, please.
Yes, I am ready. Assalamu alaikum. Thank you so much for having me. I'm going to share my screen. Let me know if you can. Can you see my screen?
Yes, we can see your screen.
Okay. I'm going to start presenting Cochrane Library, getting started with Cochrane Library search. Cochrane Library is one of the search engines that we use, or the databases that we use for our research, like PubMed, Sinaho, and many of the other databases. So if you search Cochrane on Google, this is the first homepage that you are going to see. And you can also make an account on the Cochrane library with your email and create a password for that and create an account on there. So when we start like searching, you want to click the advanced search bar. If you click on that, you can see like 4 tabs that appear: the search, and then the search manager, the medical terms or the mesh, and then the Pico search. So the first bar is a search, is just basically searching keywords, or just write any term like blood pressure or hypertension. The next one is the search manager. It's used for complex searches, like if you want to combine multiple phrases together at the same time. By clicking that plus sign, you can add like multiple terms together, and then you can look for them, all of them together. The third tab is medical terms or mesh. So this basically, if you write blood pressure, if you want to search for blood pressure, and you click search on that, it will actually give you the medical term. So it will actually give you the results like hypertension. So here is an example. I searched hypertension, and these are the results that you're going to see. It will tell you the definition, and then the thesaurus matches, and then it will tell you the mesh trees or medical subject trees. You can either expand those, or just like expand those or not expand those. And then you can see how many search results that are there. And if you click add to search manager, it will take you to that complex search bar over here. And that's where you can add more complex words. For example, you create hypertension and treatment and something else. Also, saving your search results is very important, especially doing systematic reviews, because sometimes they will ask you, like, you want to make sure that your results are reproducible. So you want to make sure to save your search results and serve the exact terms that you typed in. And if you want to view all the results that appears, you can click on view results. And here you can view the saved searches after you clicked save. If you want to start over doing another search, you click clear on that and start another search. One thing also, like to limit or either to widen or limit your search findings, you can filter your results. For example, you can look only for the publications that are in the last 3 months based on the publication date. Or if you want to look for it in the last 9 months, the last year, you can filter that from here. Or also, okay, when you start your systematic reviews, if you want to do a systematic review search, the first thing you want to do is scoping. Scoping means basically just typing in, like in Google, for example, about your topic. And just to see how many literature review is available on that topic, and it's whether it's feasible, like you're gonna find a lot of research on that or not. So I just talked about saving your research history to see if your database offers reproducibility of results, and make sure you document that too. So the main thing here, how you search on the Cochrane, it either makes or breaks the results you're gonna find. So basically, we have like search strategies or certain operators we can add to our search bar. The first one is Boolean operators. Boolean operators are words that let you expand or narrow your search parameters when using the database or search engine. The examples of the Boolean operators that we can use is or, and not. Here's a picture about how many articles you're gonna find if you use and or not. In the first picture, there's a search of genetics and cloning. So you're gonna get articles only, you're gonna get the article that only contain these terms together. So genetics and cloning together. If you use the operator or, genetics or cloning, that means you're going to widen your research. You're going to find all articles that contain the term genetics and all articles that going to contain the word cloning. And if you use the not operator, genetics, not cloning, you're only going to find results showing genetics. So and or not are the three Boolean operators named after George Boole. Combining the two words using and will fetch articles that mention both the words. Using or will widen your search and fetch more articles that mention either subject, while using not to combine words will fetch articles containing the first word but not the second, thus narrowing your search. Another thing we can use on the search bar is paracentesis or brackets. So when you use the brackets, this is called the strategy is called nesting, basically like grouping the search words together. Example, if you type it in the first bar, diabetes mellitus, and use the operator and then use the paracentesis, type in metformin or sulfonylurea. So this means it's going to look for articles that contain diabetes mellitus and the treatments, metformin, or sulfonylurea means can contain metformin and sulfonylurea. Another thing we can use are the truncations or asterisks, like the star shape. It is used to find various words ending and will retrieve variation of the words, such as plurals and nouns. For example, if you type in develop and then add the asterisk or this star, it will retrieve all the words basically that will end in different endings, like development, developmental, developmentally, developments, and etc. But you want to make sure you use it very carefully too. Like for example, if you type in cat, it will retrieve catalog, catastrophic, catatonic. It can like give you different results that maybe not matching what you're looking for. You can use also truncation symbol in conjunction with phrase searching. For example, the quotation marks, tandem, repeat, and then you add the asterisks will return the same results. Tandem repeat or tandem repeats or tandem repeating. Basically, you're just adding ing or s after that asterisk. The fourth tab that you can see in the Cochrane is the Pico search. Cochrane Pico search is a powerful and easy use tool for finding Cochrane reviews. Find reviews that answers your research question. So when you want to start a systematic review or a research, you're going to have a research question like who, when, and then you want to see if you have an outcome, you want to see if you have an intervention. So this search engine can be very helpful in finding your research question exactly. So PICO stands for population, intervention, comparison, and outcome. And this is an example. I typed in hypertension in the mesh medical subject term. And these are the results that I pulled out. If you see below each article, you can see the PICO questions. You can click show PICOs and it will give you these 4 parameters, the population. If you want to look for hypertension in adults, hypertension in children, and the intervention, blood pressure monitoring, the comparison, if you have cases and controls, and the outcome. This is the 4th tab, which is the PICO search. If you want to look using the PICO term. So select the PICO search tab, enter the search term that you want to look for example, asthma here, and then you can type in if you want it to be the population or the outcome or the investigation or the Okay, it's when you are done with searching, it's very important to export your search results. So the Cochrane library allows you to export and download the citation informations from either the single authors that you want or from the multiple articles that you can find. So citation export files can be used with the following reference management programs. So these are programs that can actually cite all the articles that you want or a single article. The programs like EndNote, RefWorks, Mendeley, Zotero, Wail, Reference Manager, ProCite, or Excel. All of these can be used, like we can use them to extract our citation. So I have tried Mendeley, and some people are using EndNote too, and I have tried Excel. And I'm going to show you an example of how to use them to cite search results. First of all, when you go on the search engine, you find the search results, you can select all the articles that you want, and then you click cite these articles. And then it's going to ask you for the format of the citation that you want. If you pick the RIS format, this means you are going to use one of the reference managers that are here, like EndNote, RefWorks, or Mendeley. So I downloaded, like I told you, Mendeley, and I'm going to show you how to use it. I'm going to go to advanced search. Then I'm going to go to mesh terms. If I want to load the same thing, attention. Look up, and then I'm going to go to view my results. And it looks like if you want Cochrane systematic reviews, and then 25,000 trials. So you can either choose you want like results from trials or from the systematic reviews. If I click, I want to cite all of these articles together, I can click select all. and then export the selected citations. And here it will tell you choose the format that you need these citations. RIS, the RIS format for any of the reference managers, like I told you, like the EndNote, or reference managers like Mendeley that I downloaded, and then ProCite if you download that. BibTeX is another reference manager program, or Excel. So I'm going to use reference manager and click download. So you can see here it downloaded a file ending with RIS format. And then if you download the program Mendeley Reference Manager, that's what it looks like. That's your home page. You can actually make an account too in Mendeley. So the first thing I'm gonna do is download the file that I just downloaded here in this page. I'm looking for my This is the citation. I'm gonna drop it here in this page. It looks like oh yeah. So when you drop your RIS format here, all of the articles that you just clicked in, the 151 articles, they're going to show you the citations over here. So it's going to tell you the authors, the year, the title, and then the source, where you got it from the Cochrane database, when did you add it. So if you follow these instructions, then you can do the same thing on Mendeley. So next, I want to do the same thing, cite all of these articles on a simple Excel format. Like you can either have a PC or a Mac. So if you have a PC, you're gonna do the same thing, cite all articles, and then click the text or CVS form, and then you're gonna open a new spreadsheet in Excel and import the files using comma delimited, and then click the file style Unicode UTF. So I just opened a new spreadsheet in here in Excel. And I'm gonna go to my Cochrane search. I'm gonna click this time. I'm gonna use CVS Excel format. I'm gonna download that. See, it's downloaded. And then we're gonna click on data here and then get data from file. And then I'm going to look for the thing that I just downloaded here. The CSV is the Excel form. And then I'm going to click import. And then I'm going to click load on this spreadsheet. You want to make sure you start on the first row and the first column. And then all of your 151 citations should be here, or the article that you selected. It's going to show you again the Cochrane ID, the authors, the title, where you got it from, the source, and the year of the abstract. If you have a Mac PC, you can use like a different method. All of these like instructions can be found like in the Cochrane website too. How to export the data. Even they have like helpful training videos on their website, and they have also PDFs that can show you how to use the Cochrane library to search for systematic reviews on their website. Thank you very much. If you have any question.
Thank you, Razan, for your nice presentation. And Cochrane is a very important database, and as well as other databases like PubMed. Every researcher need to master these databases. I would like you just, if you can go back to paracensis and nesting, can you explain to us a little bit about that?
Yes.
Because I think you use to find the relations between two items. Yeah, go ahead.
Two brackets, yeah, two brackets.
Okay, you can use and or. Very good.
Yes, I'm going to use the and, which is the operator.
Okay.
For example, but the paracentesis is like using the brackets, and then I'm going to use another operator, which is the or here in the middle. Or you cannot use it. But paracentesis like helps you to group what you need in brackets.
Excellent. And it is used often. The paracentesis and nesting are used very often, and also it tells us the relation between the two items you are searching. Very good.
And
any other question, guys? Yes.
I want to tell you that if you're looking for the same thing in PubMed, for example, or another database, it could be different. It could be different if the actual database can give you results if you use an asterisk, for example, if you use brackets. So some databases will not turn actual results because they do not use these like brackets, for example, or asterisks. So you want to make sure if your database actually uses those and can give you results when you type this in the search bar.
Any questions, guys?
Yes, Dr. Ahmed, there's a question for Dr. Razan from Dr. Nada in the chat saying, can we do the same using CSV format on Excel Google Sheet?
Can you repeat the question? Use the RIS format on what?
Can we do the same using CSV format on Excel Google Sheet?
Google Sheet? I don't know actually. On Excel Google Sheet, is it the same thing like Excel program? Not sure about Google Sheet.
Can Dr. Nada, are you able to unmute yourself? And
Can you hear me?
yes, we can hear you.
So I just wanted to ask, for example, if I had I'm using an Excel Google Sheet instead of the normal one, so everybody could access it and someone
Okay, let me try, but I've never tried this.
Yeah, that's why I was wondering.
Okay, looks like it's the same thing in Excel. Okay, I'm gonna start here at the first row and then look for data. It doesn't show like import like the one before. Maybe it's a different technique because I can't find, if I follow the same instructions from Cochrane, it will tell you click on data and then it needs to show a bar here, like import the file, but I can't see it. Oh, there's import.
And then you
But
can
why
find your file.
What?
Your file where you.
Yes, but it's taking me to my drive. It shouldn't take me to my drive. I want to go to my downloads. Not sure if I
can try upload.
Yeah.
Maybe upload the same file in my drive. Okay.
And maybe it needs a different format. I'm not sure.
Maybe, but let me see. Drag a file here. Browse. I'm gonna upload the file here in my drive and see. Citation CVS.
Yes, absolutely.
Open. Okay, import data.
It's coming, right?
Worked.
Yes.
Yes. Looks like it works in Google spreadsheet the same way.
Yeah.
Thank you so much, Dr. Razan.
Thank you. Razan, I want to add one thing. Thank you for mentioning the reference managers and especially the EndNote. I have bias to EndNote and I use it very often. So I advise everyone to use that. The only thing is that you need sometimes to pay money for it. Or if you are working at an institution where they purchase the software, you can use it. But it is very user-friendly and it is used widely, the EndNote. But there are many, as you mentioned. But thank you for mentioning that.
You're welcome.
Yeah. I use it very often.
Okay.
And also, like, if you go to YouTube, you can have a lot of videos that you could familiarize yourself with the software. So can we, any other question, or we can go to the next topic?
So I have a question actually. So after I did this, the citation, when you actually write the research, you have to do it in a certain format, right? This doesn't give you that format, like the APA format, for example. Do you have to write the whole thing yourself, or actually use another application to write it in the specific citation formats? Looks like the doctor logged out or can't hear me.
Yes, I think let me try answering your question, Razan. So
Yeah.
when that usually happens, usually we can use applications or websites like SciSpace, or maybe searching for the research paper on PubMed, and then you can change or choose the type of citation that you want, whether it's APA or AMA.
Okay, so in PubMed I can do that. Looks like in
Yes.
Cochrane I can't. I need to look for something else to do that because
Yeah, I think
because
like
this format is
using
not an APA format. Yeah.
so just using the link from the Cochrane and then putting it in, for example, SciSpace, and then it can manage for you the citation type that you need.
Okay.
I hope
Okay,
that
thank you.
helps. Yeah,
Yes, thank you.
welcome. Thank you very much for the presentation. It's very useful, and hopefully so many people will be able to use what you shared today. Thank you very much.
Thank you.
So we can, I hope Dr. Ahmed is with us. We can move to the other part.
Yes, yes, I just
Yes.
kicked out, but I'm back again. Thank you.
Welcome, Dr. Ahmed.
Yes, we can go to the next topic, if you will.
Okay, I'm going. First of all, greeting everybody. My name is Shaymaa Abdelmalek, and I'm going to present for you the Loom presentations and all what you need to know about Loom. I'm just sharing my screen. Give me a second. Everybody getting my screen?
Yes, I get
Okay.
your screen.
Okay. So thank you so much, Dr. Mufaz, for hosting our first meeting. Me and Dr. Ahmed worked on these presentations and here all what you need to know about Loom. First things first is to know what is Loom. Loom is actually it is a video recording and screen sharing software that is very useful for teams. It is user friendly. You can use it with any kind of device, whether you're using Android or desktops or iOS. It is free for as long as you are not exceeding 5 minutes of recording and a total of 25 videos in your library. If you need to exceed this, you might need to upgrade yourself for the paid plan. To get started with Loom, it is as simple as this. You just need to write in your browser loom.com and just navigate to it will launch the main page, and you need to navigate to the tab which is saying Get Loom for free. And by clicking on this one, you will be able to go to the page where you will able to sign up with where the options which is suitable for you. It could be Google, Apple, or whatever. And you need to create your own account by just adding your email, give name to your workspace, and adding your audience or your member. This is some of the features about Loom. It is again all about screen sharing and screen and video recording. It gives instant sharing options and real-time webcam recording. Here is the main page and how it looks like after you create your own account. This is the username. And here from these options you can, sorry, I'm not using the pointer. Here is the user or your account name. And from here you can add your team members as much as you can. And I believe in the free subscriptions or free plan, you have up to 50 team members you can add. This is about the homepage, your library, which contain all the video which you recorded. And this is about getting any notifications from any viewers for your videos. And if you wanted to start to record your video, you just need to press here, which is saying record a new video. And this number is showing the your balance of videos which you are allowed to do for free, which is 0 out of 25. If you need more than 25 or more than 5 minutes of recording, you need to upgrade. To start recording a video, this is the page. If you will get it once you click record a video. It will open this right side dialog, and from this dialog you will have an option to select what you are going to record. Are you recording your full screen or specific window or your screen and camera as well? What you have to pay attention to is this two. This is your camera and your video and your mic. Some people are using more than one camera or more than one mic in their devices, so you need to select your setup and click start recording here. Once you select start recording, it will take you to another page where it will ask you what you wanted to share. Here is, if you are going to use from your Chrome or your device, you need to select it and you click share. And from this dialog, you need to select Loom or Loom library and also click share. And once you record a video, you actually, I don't know, it is not showing here because I did not work on the slide myself. This is done by Dr. Ahmed. So once you record a video, there is this kind of panel. You see it here. As long as the recording is going on, you can either click here to stop the recording, and this will save your video in your library, Loom library. This one, if you click it, it is going to pause your video for sometimes if you wanted to adjust anything or adjust any setting in your recording. And this option is for deleting the record or canceling the record completely. And if you click here, you will be getting another prompt screen, which is saying, do you want to delete it or no, or you want to resume? Once you record your video, it will show up in your library, and this is my library, and showing here one recording is there. In this screen, you can preview your recording to see is it the right thing that you want to really share it with people, or you want to delete it, or you want to adjust it. By clicking on this line here, you can rename it. You can rename your video. You can also preview it. And in the next screen, also, it will give you some other features where you can just add trimming to your video if you wanted to cut from the end or you cut from the beginning, or even if there is any part of the video which you are recording or you want to clip it and you don't need to show it to others, it is just simply by adding some trims and adding some clipping to the video. And that's all. And I can show you some practically. Let me exit this. Here is my Loom library. Okay. And if you want to record, simply record a video. Sorry for that. Click record a video. And here is this dialog, which I'm saying you can control your setting from it. From this, you can choose if you wanted to go for full screen, window, specific window, or your current tab, or you just want to use the camera only. Here is the camera, sorry. Here is the camera, here is the setting, and I'll just go for start recording. Sorry for all this mess. I have a problem with my computer, I believe. Yeah. And here it shows what you wanted to share, what you want to share. For example, I choose my device, and I choose Loom library, and I click share. And here it start recording. And once I click start recording, it will give you a countdown, sorry. And this countdown is a good idea to reorganize your thought and arrange yourself for the recording. And here's actually starting the recording. This is the stop button, this is the pause button, and this is the recording time. If I click stop recording, already shared your video in your library. And this is my recording. If I want to just name it or give it another name, I just click here, and give it a name. Okay, and if I wanted to share it, I'll just click on this copy link and I can share it with others. Another option for sharing is to just click the share button, and you can here, it will give you an option to add the emails or the names or your team members. And pay attention to this drop-down menu, because this will show you, or will give you an options to select whether you wanted to share it with the people who access the link or the people who is just in your workspace, or you can give it to, you can add specific people for getting your recording. From this share option also, you can, if you wanted to put your recording in any of the social medias like Twitter, Facebook, anything, LinkedIn, anything, you can also add it. And embed, you can also like put your link in any online page. During you in your library also, you will get a chance to see if your video really gets some viewers, some audience, you got somebody who comment or give you a feedback on your recording, it will be also written. Okay, it will be down here. That's all about Loom, and I hope it is helpful for all of you. And if you have any questions, I'm ready to answer. Me and Dr. Ahmed as well.
Thank you, Shaymaa. It's really nice presentation. And I think the software is good. And by the way, how much is cost subscription-wise? Do you have any idea?
Actually, the free one, as we said, it is up to 5 minutes of recording and total of 25 videos in your library and 50 participants in your group or workspace. But if you want a higher upgrading, the subscription will be like around $8 monthly. And there is, I believe there is even higher subscriptions, but I don't remember how much it was.
Thank you.
You're welcome. We are happy to answer any questions if you have, me and Dr. Ahmed. Anyone have any questions about Loom?
Have you experienced with something called Kezala? Shaymaa?
No. No.
There is another platform called Kezala. Have you heard about it?
No, I never heard about it.
Yeah, I'm just like try to compare and to see if you have any idea about that. But it seems to me like it's a very good software. $8 a month is not that a lot. Is really reasonable. But I think higher upgrades could be more than that.
Yeah.
Any question to Shaymaa and Ahmed? What do you think? If there is no question, we can go to next topic.
Yes, Dr. Ahmed. Thank you very much for Dr. Shaymaa and Dr. Ahmed Yasser for the perfect presentation about Loom. We can move on to the next, our last presentation for the day about nephrology and geriatric, presented by previous fellow Dr. Azza and Dr. Wail. So if you guys are with us, please unmute yourself and join us.
Research Fellow, and I think we were the first batch. It was a very useful experience, very resourceful. We were very thankful for it, and it provided some sort of very much needed support for us. I believe all of us is going through the road and the journey to residency. It is not as smooth all the time, but the experience was nice. And I gained so much good friends along the way. And I wish everyone the best, and everyone who is interviewing, I wish them the best. So I'm currently, so brief about my experience. I'm currently nephrology fellow, second year nephrology fellow at Thomas Jefferson in Pennsylvania, Philadelphia. So briefly about the experiences, like for me, basically, I applied for the residency several times, and unfortunately, I couldn't match. After that, I had a friend who had the similar experience, and she found an opportunity in the fellowship. For me, my advice is to be persistent. Try to apply to fellowships. And right now, I think this is a good time to apply for fellowships. If you haven't applied, or if you're thinking about applying to fellowship and you are not making your mind, this is the time to do that. Send mass emails. You can try and get all the names of the fellowships. It is either nephrology, geriatric, and infectious disease. Get all the names of the fellowships or the program directors' emails. I know it's going to be a bit of time consuming, but I think a couple of you can do it together. Like if like a group of you could, everyone can assign to like two states or one state and collect the names or the emails of the programs. And then you can send mass emails. I personally, I have sent 150 emails to all the programs. And of course, it's like one click, so you can send a blind copy to all the other programs. So you will get the responses. A lot of the programs that will not like announce that they have vacancies on their website, but they do. And right now, I know that most of the nephrology programs went and filled during the latest match. So especially if you have step 3, I would recommend everyone who has that to do the step right now and go for it. You got nothing to lose, and it is completely free. You're just sending emails. Just put a little bit of effort to it. An email, try not to make it a very long email, and get a brief about you and 1 or 2 sentences, and a bit about your experience and a bit about your citizenship status or your visa status. And after that, you can attach your CV for the person to look into it further. So yeah, for me, it was something like that. I did the same. And I was also lucky to have my friend who had the previous experience, the same. And she guided me through it. And fortunately, I was able to match to the Nephrology Fellowship. So basically, I believe that was my experience in brief. Sorry if I went through some stuff very quickly. If you have any question, guys, you can jump in at any time, interrupt me and ask me. I think I'm not sure if Wail is here, but I believe Khalid is here, and he can also tell you about his experience. So if you have any question, I will be happy to answer. You can email me as well at any time. I believe this. Yep. Thank you so much.
I have a question. Sorry for interruptions. I wanted to know, is the fellowship training in nephrology require home country residency and the previous training as well?
So they do require a residency like training. You don't have to have an MD from your home country. You can have like 4 or 5 years, 3 years. You can call it like a residency equivalent training. So that's what I did. A lot of the programs will accept that. No issue.
Congratulations, Azza.
Thank you so much.
Yeah, this is great. And have you finished your nephrology fellowship yet?
So this is my 2nd year. I'll be graduating in June, so almost done.
Okay. And are you planning to apply? Are you applying for residency?
Yes. So I'm currently applying right now,
Yeah.
or applied.
Yes, and this is really, this is very good, and will increase your chances to get into residency.
Yes, of course.
And then you are like you are competitive among your colleagues. You already completed your nephrology fellowship. Some of people who came to residency completed like geriatrics fellowship, and these are all very useful experiences. And I have a bias to nephrology, and nephrology is really is very tough fellowship, right, Azza?
Yes.
Yes,
Yes, I agree,
yes,
Dr. Ahmed.
yes,
Yes.
and there is a lot of work, a lot of basic. And by the way, nephrologists are called doctors of doctors, so you know a lot. So
Well,
you
hopefully.
yes, and as you know, when they consult you, you sometimes find yourself practicing endocrinology, especially when you are in the field of secondary hypertension. Sometimes you find yourself you are a rheumatologist, especially when you are dealing with vasculitis. And also when you are dealing with SLE. So it's really a very tough kind of training. Good luck. And you are a
Thank you so
great
much.
example for those who are seeking residency. And I'm sure you will do what you want, and the others will join the residency as well. Thank you for
Thank
your sharing your experience, okay?
Thank you. Thank you so much. Thank you, Dr. Abdulrahim. Thank you, everyone. Thank you for giving me the time. And a big thank you to Dr. Nadir also. I believe he's not with us in the meeting, but for creating this fellowship and the opportunity for everyone. Thank you so much again.
Thank you.
Here they go.
Hello, everyone. My name is Khalid. I was first class joining the Telegeriatric Research Fellowship as well. I finished my USMLE after a while. I think since I graduated and I came to the United States, it takes me like 6 to 7 years to finish my USMLE exams. And after that, I applied the first year and there was no lack of matching. And after that, I joined the Telegeriatric Fellowship Research and I matched. And I will finish my internal medicine residency by June of this year. What I will say to everyone in this group, never give up. Persistence is the key to this journey. There's like ups and downs. As I mentioned, just continue do any kind of work, clinical research, expand your networking, send emails. By the end of the day, you will find an access because I know the journey, and everyone invest a lot from their time, their family, their financial resources. So just keep trying, and by the end of the day, I think everyone will match. Just persistence is the key. And good luck to everyone. And this is my brief experience. And if you have any questions, I'm happy to answer them.
Thank you, Khalid, for sharing your experience. Why you are practicing now?
Right now, I'm practicing internal medicine residency at Wail Atlanta Medical Center in Atlanta, Georgia. And I'm heading to Wisconsin to practice as a hospitalist.
Very good. And this is great. And thank you for sharing your experience. As you said, I'm echoing your words. Persistence is a key. And thank you.
Thank you.
Hello.
And I think our colleague Wail is also here. Some of our colleague or our class, I think they can share their experience and hopefully maybe to help people if they have any questions and to support them during their journey. Thank you.
Hello.
Hello. Hi.
Hello. Thank you, Dr. Ahmed, and thank you, Dr. Khalid, for the informations and for the support. I am actually applying this year, and me as other colleagues from also this group, we're now waiting for the match results. As you know that the ranking has already opened. So my question is actually within the same context, is that like we want to know like, does the letter of intent, because now we know that like most of the programs, they're finalizing the rank list. So does the letter of intent or reaching out to the programs to update them about, you know, things that we have done within this duration, does it matter or does it make a difference? Thank you.
Rufaida, what's your question? I'm sorry.
Oh, so I was wondering if you know, reaching out to programs that we interviewed with at this point of time, to update them about if we have new publications, or if you know, to send them letter of intent to tell them that like you're my number one choice, or that we're intending to you know, to match at your program. So does it make a difference in creating the rank list from within the programs, or does it affect the chance of getting match?
I'm gonna, yes, from my experience, everything you do matters. Okay, when you show your interest, okay, you update, if you have any update, like as you said, publications, or you passed step 3, and if there is any way that you wanna update the program, that is very good. If you have connection inside the program, that will be perfect. So anything you do, it matters and it helps. Sometimes the program directors make their they decide earlier, but it is always just keep hammering. It doesn't hurt. Okay, so especially, for example, if you are aiming at a certain program, you can always send to that program, and you can even ask for a second visit. Okay, and if you know somebody up there, that will be great. So don't stop trying till you match.
Inshallah. Thank you, Dr.
Thank you.
Thank you.
Hello, Razan, do we have any other presenter?
Hello, Dr. Ahmed. We do not have, that was our last presentation. However, now we moved on to our updates from our colleagues. So if anyone
And
has any updates.
just a quick, we're supposed to have a discussion about CKD in elderly, or that's not today?
I believe this is not part of today's agendas. No, maybe it's probably next week.
Okay, very good. Okay, so let's go for our update. Thank you.
Thank you. Anyone has any updates or any new ideas you would like to share with Dr. Mohamed Abdelrahim, please go ahead.
I wanted to ask if there is a chance in the future to have like a presentations about EndNote and functionality of the EndNote, because I know that it is a very, very, very valuable tool in research.
Shaymaa, you mentioned about the EndNotes.
Yeah, I wanted to know if there is any chance in the future to get a presentations about the EndNote and all the functionality of the EndNote and how to use it.
Absolutely, and we will make that happen. And thank you for brought that up.
Thank you, Doctor. I
It is
appreciate it.
great software, and also I can discuss that, or any one of my colleagues could discuss that. But it is widely used, especially in my institution here. Another thing I would like to share with you, or I would like to encourage you that research, like in this kind of fellowship, we like to generate more papers. So I would like each and any one of you to come up with article, or we can suggest some research topics, and really it helps down the road. You know that when you are having papers and you are applying for residency, that is matters a lot. And also I encourage you to take any kind of courses online, certificates, master degree, and that is all will help. So in research, like review articles, it helps a lot. Sometimes, like if we have time, we can hit all the spectrum of research, starting from the basic, translational, and clinical research. But right now, what we have at hand is clinical research. Okay, so that is help. And before doing any kind of research, you have to arm yourself with the knowledge. That is the review articles. And the presenter today enlightened about one of the tools, which is Cochrane, and all PubMed and other databases. So this is all will help us. So any one of you, I would like him to be a very strong in research. And when you are doing the research, you feel like you are not consuming the knowledge, but you are only digesting the knowledge, but you are generating it. And that put you as a top when you apply. So during the interview for the residency, remember, if you have a paper, they want you to talk about the paper, and they want you to see how potential are you to publish while you are a resident at that program. If you could prove that, you will get in the residency. So read, research, and learn as much tools as you can during this fellowship or during your time in the residency. But I'm sure all of you will join the residency, and really what you are presenting is great today. And thank you so much for what you have done. Thank you.
Assalamu alaikum, Dr. Ahmed.
Assalamu alaikum, Rayan.
Yeah, actually, we do have an update. So we're going to be working on a new topic right now. I sent Dr. Nader an email, but it's going to be focusing on PCOS and cognition. So I was reading on this one article. There was a new study that came out that linked PCOS to people who have cognitive decline. And so we were trying, like, I know with insulin resistance, that has to do with, there's a link between that and cognition, but PCOS, this is something new. So when we did our first initial search, we didn't find too many articles, but as of right now, it is a new topic. And so inshallah, this is something we're going to focus on. And we actually also had one of my fellows within the project, a PGY2 internal medicine resident, actually reached out to us, and they're interested in joining our specific project, inshallah, to collaborate with them and hopefully get it published.
Absolutely. This is very interesting, Ryan. And please, if you can share that with me and with others, it will be great. And you can even send it via the email if you can. Can you do that?
Yeah, absolutely. If you can share your email, Dr. Ahmed, I can definitely do that.
Absolutely. And this is really very interesting.
Yeah, no, of course. Yeah, it's a group of I think we're a group of 7 right now. So alhamdulillah, the group is very like determined and dedicated. So hopefully we're able to find enough studies and we're able to work on it. I also wanted to connect with you as well about a protocol. In the past, I've done protocols for some studies, and there's some studies that I've published without a protocol. Because this is something new and, there's not much studies that have been done on it before, would you suggest I do a protocol just prior to starting everything, or what would you suggest?
Let me see and what you have done, and then I can give more specific recommendations.
Okay, sounds good.
Yes.
Inshallah, I'll touch base with you, and then I'll keep you updated, inshallah. Thank you so much, Dr.
Please do. And yesterday, yes, I remind you about this is yesterday I talked with one of the professor here at Mayo Clinic, and he is a professor of medicine and clinical pharmacology. So, and especially rare findings or rare disease, sometimes you need to study them at molecular level, like you do functional studies. You see the molecule, and then you do functional studies on that molecules. We have a lab or some researchers who are dedicated to that. For example, you are kind of the clinician. They need you, okay? And you can even share in the lab and provide them with a sample. Okay, and the samples that will generate the data which is going to address our questions. So let me see exactly the topic, and sometimes the clinical review will lead us to do further studies. Okay, so that is that. It seems interesting. Thank you.
Thank you so much, Dr. Ahmed. I appreciate it.
Absolutely. Any other update?
Sorry, it's me again. There is another update as well. There's another topic that I'm working with another team. So this one, we looked into precocious puberty. So what we found was, did COVID-19, did precocious puberty occur earlier due to the COVID-19 pandemic? And so right now what we're looking at is the link between, was it the isolation? Was it the stress with the hormones? So we have different factors that we haven't necessarily been able to assess yet. We're just doing the first initial screening. So we're just combining all the articles. And so some articles are linking it to the isolation. Some articles are linking it to the stress, which is affecting the hormones within the patients. But this is a topic that we're focusing on right now. So it's still in the first early stages, but hopefully we're able to finish off the first part of our screening and then be able to clearly identify the reason.
Very good. I want to comment on this because also this seems interesting. So your patients are blue, your patient age is the range. Can you? What's the range?
So for precocious puberty, so for males it's 9 and females it's 8. But what they found is it's presenting earlier, and so they're wanting to know, what does it do? Because I guess with the studies that we've assessed so far, they're saying that all of these changes have occurred during the pandemic. And so, like I said, some studies are linking it to the isolation, some studies are linking it to the stress. So we haven't necessarily refined our search. I haven't looked clearly into the analysis of every single study. So we're just at the first steps. But what they found is it's happening earlier. And
Okay,
so
so
we're focusing it from 2020 up until now.
okay, so what other symptomatology? Is this patient like having any pronounced like heart symptoms like palpitation, syncope, presyncope? Do they have chronic fatigue, pain? Any one of these symptoms predominates? Because I want to comment about this, if yes or no. Ryan, you hear me?
Yes, I'm here. Sorry. So I don't have that yet. Like I said, we haven't done the analysis. So maybe next week I can update you further to see exactly what we've been able to get out of the studies that we've analyzed.
Okay,
That's
so
it.
very good. So why I ask this question, because post-COVID, even if it is mild, people have complications, something called central sensitization disorder. And that is if you do an MRI, there is no structural abnormalities in the brain, but if you do functional MRI, you find more signals. That tells us that they have functional abnormality of the central nervous system. And it could be, and your hypothesis could be right, that it affects down the road the hormones, because really it affects the hormone, because sometimes people have PATS, postural tachycardia syndrome. And why is that? Because that is due to hyperadrenergic state. Okay, they could have chronic pain, widespread kind of pain, fibromyalgia kind of pain, or they could have a chronic fatigue. Okay, so this are all central nervous system disorders and through central desensitization. So very interesting. Once again, you can share that, and it is possible because the post-COVID symptom and post-COVID syndrome is really a new thing, and people are learning about it. Okay.
Yes, absolutely. One of my fellows as well, Dr. Haifa, was just mentioning, she also found some studies related to the BMI. Some studies also spoke about enlargement of the uterus. So there's many different factors, I guess, that have been linked to this topic. But inshallah, like I said, hopefully this week we can look further into it and then be able to come back next week with a more defined answer.
Excellent. Thank you.
No problem. Thank you, Dr. Ahmed.
Thank you. Thank you.
Hello.
Hello.
So also within the same context, me and Dr. Ala will be representing, the fellowship. We will be presenting 2 posters at the American Academy of Neurology on April. And
Congratulations.
Thank you. So my topic is also within the same context. We will be talking about the neurocognitive implications of COVID-19. So it's post-COVID. It's also another post-COVID syndrome. And Dr. Ala's topic is actually she wanted to update you, but today she's not here. So me and her, we're currently preparing our posters, and soon we will be, presenting the posters here before sharing it within the meeting. So we would like to reach out to you after the meeting in order to coordinate how are we supposed to be doing the poster and everything, if that's fine.
Absolutely.
Yeah.
This is very interesting. And the other thing is that I would like the abstract is to lead us to paper. Okay.
Yes.
So this is I'm looking forward for your topic, and we can discuss it. Okay.
Thank you. Thank you, Doctor.
Thank you. But thank you for sharing.
Thank you.
Dr. Ahmed, I actually believe it's going to be published, because Dr. Hafid was saying she's presenting this year.
Yes.
I presented last year at the American Academy of Neurology, and so after the presentation, they actually publish it in the Neurology Journal. They have a journal that's linked with the Academy, and so inshallah it should be published, I think, 6 to 12 months after they present it in person.
Absolutely. Very good. Thank you.
And we're also working to generate the manuscript, and then hopefully after the conference in order to publish it, a full manuscript. inshallah.
Absolutely, and that is what we need. Like, it generates papers, like it leads to paper.
Yeah.
Okay, very good. Any other update?
Yes, I'm working with Dr. Ryan in the topic about the precocious puberty in children regarding post-COVID-19. And as you mentioned, the cardiac effects of COVID-19 in children, we recently read about the effects of COVID-19 itself on the ACE receptors, and that's what caused the cardiac effect. So there was reports of fatigue, there was reports of cardiac problems due to the COVID-19 in children, as well as a similar effect with ACE in receptors in the pancreas and other organs that has a receptor, such as the ACE receptors. I just wanted to add this, and I wanted to get your point of view. Is that what you meant when you mentioned the cardiac effect?
Absolutely, and this is great. And whenever we find a research that connect the phenotype with the molecular weight, molecular basis, like the phenotype, I mean like what you feel, dizzy, lightheaded, is there any hypertension? You connect it with the genotype or the product of the genotype. That is really solid science. So this is very interesting. Okay, I'm looking forward to see you, to review your work with you, if you will. And thank you for telling me about this.
Sure. Thank you very much, Dr. Ahmed.
And just to mention one thing, like nowadays you use medication, especially like this COVID-19, it tells us a lot, okay? You use medication and for example, let's take Coumadin, okay, warfarin. Some people are therapeutic within 2 milligram, but some of them are 20 milligram, and then they will be at the therapeutic range, okay? This tells us that the phenotype of having therapeutic INR is be like only caused by 2 milligram. But how about when we use 20 milligrams? That means the genotype of the individual is completely different. There's something going on. And when they did the DNA sequencing, they find the abnormality. And this is the whole game of pharmacogenomics, or the field of precision or individualized medicine. And usually we used to study in pharmacology, pharmacokinetics, what the body does to the drug, and pharmacodynamics, what the drug does to the body. But nowadays we have to study the pharmacogenomics or pharmacogenetics. And this is what I mean by phenotype and genotype. Any disease, if we have a facility that could study this, that will be great. So especially why I mention this, because now you have COVID-19, but we are dealing with the receptors, and that is very fine talk, like you are studying the receptors, and the receptors is a product of a gene, because the receptor is protein, right? And according to the DNA dogma, we have DNA, messenger RNA, protein. So whenever you are addressing that and you make it clear in your research, this is a fine product. So I'm looking forward to see your work with your colleagues. Thank you. Any other question? Razan, does that make sense? Hello? Hello?
Yes, it makes sense. Dr.
Okay,
Ahmed.
very good.
Yes, thank you.
Thank you. We come to the end, or is there any other question? I'm not rushing you, but just try to.
Yes, this is the end of our agenda for the day.
Okay, but so thank you. And really, sorry for the inconvenience, because I should be like, I thought it is my time, but it was your time. And but hopefully we will meet you again soon.
Yes, thank you very much, Dr. Ahmed.
Thank
Yes.
you. Thanks a lot.